Thank you, JP. So Bahujan Economist is delighted to have Dr. Ashish Gupta with us today. Ashish is an awardee of prestigious Bell Fellowship and currently working at Harvard for Population and Development Studies. Um, he holds a PhD in demography and sociology from the University of Pennsylvania. He is interested in social and environmental determinants of health, social policy, and he is also trying to improve the measure of the vital statistics and the empirical indicators of well-being. In the past, his work has also highlighted the fact that the lower caste groups, as well as the Muslim minorities, have worse physical and mental health condition compared to the higher caste groups in India. One thing worth mentioning here is Ashish has also contributed to the Oxygen Deaths project of Bahujan Economist during the second COVID wave. Uh, overall, I would say like he is asking very fundamental and relevant questions in the field of health. Uh, so we are truly delighted to have you, Ashish. And just one last thing from to all the participants, I would request you to keep yourself on mute during the session. And if you have any questions, please put it in the chat box. We will try to take them in the at the end of the session. So the floor is yours, Ashish.
Thank you so much, Tausif and JP, for inviting me here. I'll try to share my screen. Um, um, Thank you so much for having me here. It's always so nice to meet this group and talk about things that basically most of us agree on. Um, I I want to say that in between the talk, my parents might arrive, so I may have to go just open the door for them. This has been a very great series, all the presentations, and I'm personally very honored to be able to present here. I want to talk about some of my past as well as ongoing work on life expectancy and the monster that crosses our path, by which, I mean, of course, caste. So, uh, so um, this is a quote from Dr. Ambedkar from Annihilation of Caste, where he says, turn in any direction you like. Caste is the monster that crosses your path. You cannot have political reform and you cannot have economic reform unless you kill this monster. The implications of this, whatever your field might be in India, and particularly in health, if you're thinking about health, then you have to think about social inequality and its various forms within Indian society. Um, so just to go further, the main motivation when we started these related projects were that Indian society is rigidly stratified along multiple axes, as I don't need to explain. But life expectancy disparities themselves have not been quantified. So if you think about other stratified societies such as Israel, the United States, Australia or New Zealand, where indigenous people have much worse opportunities for participation in social life than white people, or for instance, Brazil, there is an active agenda within demography and related health disciplines to understand inequalities and to also try to address it. But in India, there were hardly any studies, and partly because, as you would guess, is because of data limitations, right? There's widespread public and academic debate on human development outcome of marginalized social groups within India. And so within this debate, people tend to focus on, say, poverty or income. However, as we know that health, if we care about development, but to experience development, you have to be alive in the first place. And so health is this fundamental measure of human development. For this reason, life expectancy has a one-third weight in the UN Human Development Index. And yet so within this debate, we haven't considered life expectancy disparities in India. And I think as the COVID-19 pandemic has shown, There's an urgent need to improve empirical measurement of mortality from both. So if you think about mortality surveillance or epidemic surveillance, we need good mortality data. We also want to understand, okay, the government claims to do all these things. Okay, what was its impact on, for instance, life expectancy or health? And thirdly, I think finally, we just want to understand our society. So if you're thinking about what are the most fundamental numbers that we can get about our society, we care about how many people are alive and how and to what extent are they able to live, right? Um, so I just preview my findings. Hopefully you'll agree by the end of this presentation that this is what I have been able to find. So first of all, we find large and persistent life expectancy disparities by class and caste or social group in India. We also find that social group differences between the most privileged caste and say the most marginalized caste or the most privileged caste and scheduled tribes or indigenous peoples are not explained by differences in economic status. It is true that marginalized social groups, Dalits, Adivasis, Muslims, OBCs are poorer, but the fact that they're poorer does not explain the fact that they have lower life expectancies. Um, we also, I believe, have some methodological contributions. We find some encouraging evidence from a low and middle income country context on the value of empirical approaches to measure mortality. And so this shows the value of large scale surveys or improving civil registration, for instance, in contexts like India. And I think we generate true estimates for mortality rates as well as their standard errors across the life course. We need standard errors because we're using survey data here. So before I go on any further, I want to talk about what is period life expectancy. What is this creature? So it's a very important summary measure of mortality in a period and a place. Period life expectancy is not a projection. It won't tell you how much a newborn will live in their life because we do not observe that newborn throughout their life. Presumably, they will have better life expectancy, over mortality rates will decline, and in the future, they will have lower mortality and higher life expectancy. So we can't say anything about the future. What what we're trying to do when we're calculating life expectancy is we're trying to summarize current mortality conditions. So that's the formal definition. There are variations of it, but this is one I like. It's the average number of years a hypothetical cohort will live if they experience the set of prevailing age-specific mortality rates. So what is this saying? What is this saying is that okay, mortality is high in childhood, then it declines, and then it again rises up. So you take a hypothetical cohort, let's say you take 1,000 people, and they experience these current or what, let's say a period, let's say 2012 to 2016, they experience these mortality conditions. So some people in that hypothetical cohort will die at age 0, some people will die at 1, then mortality will decline, and then a lot of people will die at older ages. In this hypothetical cohort, the average age at death would be what life expectancy is. And so why do we calculate this? The problem is that we can also generate true death rates. The reason why we generate the reason why we don't use true death rate is, for instance, Kerala today has a higher true death rate than Uttar Pradesh. Now, there is no reason that we don't think that Kerala actually has higher mortality than Uttar Pradesh, right? The reason why Kerala has higher true death rate is because it has a higher proportion of older people. So it's an older population compared to UP. And so that's why it has true death rates. Mortality rises with age. And so if a population just has older people, it will have higher true death rates. So this is the reason why demographers have come up with this estimate of life expectancy. And this is why life expectancy is such a standard measure because it allows comparisons across time, within populations, etc. And across countries or across states, for instance. Um, so how do we calculate life tables? How do we calculate life expectancy or mortality rate? What we need is counts of deaths, so how many people died by age, which usually comes from civil registration, and people, which comes from things like censuses. Now we know that civil registration in India is incomplete. In a lot of countries across the world, even censuses are not complete. And in fact, uh, I'm worried that that could be the situation in India because of the COVID-19 pandemic. We don't know when the new census is going to happen, right? Um, when civil registration is incomplete, or if you're interested in, you can also use survey estimates in a subset of the population. So for instance, the demographic and health surveys, also called the National Family Health Surveys in India, provide estimates for child mortality. What happens in the DHS is that you ask mothers about all the children they've ever had, and and whether the children are alive at the ages at which they died. And so you can calculate child mortality rates from demographic and health surveys. There are also the health and retirement surveys and sister studies. So what these are panel surveys. So you visit a large cross section of the population today, and then you visit them some years later. So when you visit them some years later, some people would have died. And so you can understand mortality from these sets of surveys. There's the longitudinal aging study of India, which is a sister survey which has had its first all India way, which is now available for us. There are health and demographic surveillance sites. There are about, I think, there are two or three, maybe more in India. So what you do here is that in localized populations, so in a large number of villages, say maybe 100 or so villages, you would measure all demographic events. So you're measuring mortality, you're measuring fertility, you're measuring migration. And so for these localized populations, you can estimate mortality rates or other demographic indicators of interest. And finally, there's a sample registration system in India, which has been functioning since the late 1960s. You can think of the sample registration system as basically a nationally representative panel of health and demographic surveillance sites. So what the sample registration system does is that it visits multiple villages and measures multiple sample villages and measures all demographic measures demographic indicators in these sample villages and urban areas. Um, Now, the demographers have also contributed to indirect approaches. I don't want to say a whole lot of spend a whole lot of time on this, but indirect approaches are basically um, how should I say this politely? They're extrapolation approaches when you don't have a lot of data. And so in any extrapolation approach, one should be very careful. Um, and um, and I think there's reason to be there's reason to be skeptical of these indirect approaches. Now, one approach that we use here and that is very promising in my opinion is this question on recent deaths of usual household members. So for instance, in the fourth round of NFHS in 2015 and 16, NFHS interviewers asked, did any usual member of this household die since January 2012? If anybody had died, they asked follow-up questions on sex, age, month, and year of death. This question was also implemented in NFHS 1 in 1992-93, NFHS 2 in 1998-2000, and NFHS 5, the recently concluded and most recently available data, 2019-21. However, demographers have been really skeptical of this question. For instance, Ken Hill, a demographer, wrote in 1991, in practice, the household death approach has given very disappointing results for both child and adult deaths. So what is happening here is that you're worried that you're asking this question, but people sometimes forget the death. Sometimes people don't ask this question. That is still a rare event. So surveyors think that, that this question usually doesn't show us an answer. So we'll just not ask this question, right? So, and that's why people don't use this question, because we are very skeptical of the data quality in this question. Intimates wrote similarly, the apparent advantages of direct questions for the study of age patterns and mortality are illusory. Here, Intimates is making a case for indirect measures. You can very well think of indirect measures as poor solutions for poor countries. And this is in fact what Andrew Neumer wrote in Nature in 2022, that demographers have been part of the problem because we've helped to put Band-Aid on this for 60 years. We've developed all sorts of techniques to estimate demographic rates in the absence of hard data. So what do? We estimate age-specific mortality rates following the approach in this paper with Gupta Sudharsanan that I did. So for ages 5 and above, we use this question on recent deaths on household members. So deaths come from the question on recent deaths in the household, and in the question on the recent deaths of household members alive, information on people alive, this comes from the household roster. So when surveys are implemented, they ask this question, okay, who is in your family, what is their age, etc. Right? And so we're using this look back period of the last 2 years. So we're thinking, okay, who's alive in the last 2 years? And so for people who died, we create lifelines starting in this look back period until the age of death. And then for adult members, we create lifelines for the entire period. Yeah, until the date of interview. And then for children below 5, we use the birth history module, where we can empirically estimate age-specific mortality rates in the ages 0 to 1 and 1 to 5. Um, the use of the birth history module to estimate mortality rates is much more standard in the demographic literature. So I'm not giving a lot of details, although I think for this audience, I'm happy to if people are interested. Um, so the bottom line is that we obtain age-specific mortality rates across the life course. These are minor details. We use national survey weights. There is something called NAX when you do life expectancy calculations. This is just the person years lived by those who died. We borrow them from the National Sample Registration Survey. And then we calculate empirical standard error. So for this approach, what we do is we follow a cluster bootstrap approach. So we randomly draw clusters because if replicating the design of the survey, and then these give us accurate standard errors. This is a complicated formula to say that the standard errors is just the standard deviation of the multiple bootstraps that you draw. You don't need to pay attention to this equation. Yeah. And so you would ask first question. So does this approach generate reliable mortality rates? So in the blue here are NFHS rates. And so these are what we estimate following our approach. You can see there's some age heaping both in deaths as well as in alive people. So at 50, lots of people say that they're age 50. So this estimate is different from this estimate from the sample registration system. And then there's some fluctuations along the way, but basically we get very similar estimates across the life course of mortality. In fact, the usual concern with survey approaches to measure mortality is that you will under-report mortality, you will undercount mortality, and you will overestimate life expectancy. We in fact find that the NFHS is so reliable that it estimates lower life expectancy and higher mortality than the sample registration system. These are similar estimates for the older NFHS, NFHS 1 and 2 is combined here. Here, I think it's important to remember that NFHS 1 and 2 were smaller surveys. Age misreporting was worse. People had less education in the early 1990s. Birth registration was also less. So we find the data quality is worse in the older rounds, but it's not very bad. It's like usable. It's very much usable. The other thing that I should say here is about these SRS estimates. The SRS is also a survey. There should be standard errors on the sample registration system. They don't exist because the sample registration system does not estimate them. One. The second thing that I should say is that we actually don't know if there's some smoothing going on with the SRS estimates. We don't know how they calculate person years. So I think there are lots of details for a country of India's size. There are lots of details on mortality estimation that we just don't know as a society. And I think democratically, this is quite bad. And I think we should invest in learning more about what the SRS is doing and how it is doing. Now, these are new results that I made last week using the NFHS 5. And so these are age-specific mortality rates from NFHS and the SRS. And so this is, and so again, I think you find very similar results as the past. There are some fluctuations in the NFHS. There is this younger mortality, which I believe is underestimated in the SRS. And so in the last BE session, Dan Coffey presented results that some of this is actually maternal mortality that is underestimated by the sample registration system. There's also male mortality that I think is being underestimated by the sample registration system. Mortality is low in these ages, so it's harder to estimate. It's a rarer event in these ages, but I think still we find basically similar results from the NFHS and SRS. And if you're worried about this gap, then I think we should worry more about what is the SRS doing rather than what's happening with the NFHS. So this gets to the results that were published in early this year in Population and Development Review. So this is life expectancy at birth in years. This is in 1997-2000 for women, for 1997-2000 for male, 2013-16 from the latest NFHS female, and 2013-16 male. So let's look at these patterns. SCs had a life expectancy of 67.8 compared to a high caste women had a life expectancy of 72.2 years. So this is a 4-year difference, more than 4 years actually. Similar patterns for scheduled tribes, and then Muslims and OBC sort of in the middle. This is exactly sort of thinking about how social hierarchy and social disadvantage works out in India, right? We also find that these two sets of graphs are these two periods, 97-2000 and 2013-16, are like 15-18 years apart from each other, and still we find persistent disparities, right? It's not that it's life expectancy for every group has increased, but it's not like things have improved more for SCs or STs compared to high caste. And I think this is really worrying. People are struggling, people are trying to improve their own lives and they're managing, but there is even in that struggle, this structure of inequality is getting replicated over and over, right? The other bit that is important to remember is it's not just that disparities are just observed at age 0. We observe disparities across the life course. So in this graph at age 0, these are the same patterns we saw in the last graph. At age 15 and age 60, you still find life expectancy disparities of 3 years here between Dalit Adivasis and high caste, even higher for men. The other thing that I should say here, I think as this graph makes clearer, is for Dalit men, actually the gap was, if you think of this gap versus this gap was actually greater than before, right? So the absolute gap for Dalit men is increasing. It's not like it's closing. In fact, sometimes it's increasing. We find a similar pattern among Muslim men also, that the gap has increased in absolute terms. I want to say here that these gaps are not small. 4 or 5 years is not a small gap in life expectancy. In fact, this is 4 years is the gap between whites and blacks in the US, and so life expectancy in the US is way greater than in India, right? So 4 years is a smaller proportion of 80 years, and it is a greater proportion of 69, 70 years, right? So if you think about both in relative terms and in absolute terms, inequalities in India and life expectancy are greater than some of the most well-studied inequalities in the world, such as between Black Americans and white Americans. I want to move.
Ashish,
Yeah,
1 minute.
sorry.
Mohit has a question. So Mohit, you can unmute yourself and you can ask the question.
Hi, thanks, JP. Ashish, I just had one clarification. So
Mhm.
when you say Muslims, are you including all Muslims, say upper caste and lower caste Muslims? And when you say
Yeah.
OBCs, do they include all OBCs except in Muslim OBCs?
Yeah, that's a great question. So I think OBCs are Hindu OBCs here, and we're doing further work on Muslim OBC versus and Muslim high class life expectancy. We haven't created estimates for that yet, and so so I don't have anything to show you right now. But I think that's so along with Nazar Khalid and Sangeeta Vyas and Payal Hathi, we're doing some of this work, but we haven't generated the estimates yet. It's on the agenda. But to clarify your question, these are all Muslims, no matter what caste, and OBCs are Hindu OBCs. So in the NFHS, it's a very small fraction of the population that belongs to that is OBC and that is not Hindu or Muslim. So whether or not you include this population doesn't make a difference to the OBC number.
Okay, yeah, thanks.
Thanks for this question. So I want to move further on class-based inequalities within Indian society. And so what we do is what we do using the NFHS in a dissertation chapter for my dissertation, I did this. So we create an asset index based on the durable goods and assets that a household owns. So the NFHS asks, do you own a car? Do you own a cycle? Do you own a sewing machine? And so from those assets, which are easier to measure in survey settings, we create an asset index. And then we exclude assets with direct links to health, such as fuels and toilets. And then we create, like, again, ignore this equation. We create age-specific mortality rates for each asset class. Uh, there are some disadvantages of this asset index. One is that these assets are measured at the time of the interview and mortality has happened before. There's always this bidirectional relationship between wealth and mortality. You can very well imagine somebody dying in someone's household and some people becoming poor. And you can very well imagine that poor people have higher mortality. Uh, Although you could very well ask that if someone dies, you don't get a lot of money from selling the household mixie, right? So actually, the bidirectional relationship between wealth and mortality is less relevant for this approach based on durable goods and assets. Then finally, it's not an absolute measure, it's a relative measure. It measures where you are in a social hierarchy relative to others. We don't have absolute income or absolute asset indexes. There's some advantages. So it's available for all individuals. So if you think about other measures of socioeconomic status, such as occupation, it won't be available for women, for instance, who may be housewives, or for younger individuals who are not yet in occupation. So it's available for all ages. It's easier to collect in low and middle income settings, and then it's a marker of social status. For instance, when someone buys a car, they're trying to signal, they're partly using the car, but they're also trying to signal that they've arrived. And so these assets are also useful communication devices, for instance, in marriages and dowry settings in India. And then finally, as I said, these assets are less sensitive to shocks. This is what we find. So these graphs are by octile, and this is for NFHS 1 and 2, which we combine because they were smaller samples. And then NFHS 4 is here in blue. And so the poorest octile, so this is the poorest 12.5% of the population. This had life expectancy of 66.4 and the wealthiest had 75.6 years. So this is a difference of almost 9 years, more than that. Here for men, 60.9 versus 73.0, so a difference of 13 years of life expectancy. 13 years of life expectancy is sort of the difference between the richest countries in the world and some of the poorest countries. In the world, another way to think about it is John Reyes and Amartya Sen say that India is part Sub-Saharan Africa, part California. And so these are definitely Sub-Saharan African levels of life expectancy. These are not quite California, though this is the top 12.5%. If you did the top 1%, you would reach California levels of life expectancy for sure. You can also do by octile. So this is the bottom 5% and the richest 5%. These are sort of people like me. These are people who almost have really no assets, basically, right? So it's these people reported that, for instance, they may not have 2 pairs of shoes or more than 2 pairs of clothes. So these are some of the poorest people you would meet. And so life expectancy is 58.6 compared to 74.6, right? The difference of 16 years when you're comparing men. The other bit I think it's important to take note is that I think the rich really stand out compared to the rest of the population. And I think poorer men are doing really quite badly. Partly, I think this is driven by middle-age mortality and working conditions in which the poorest work. I have some additional results for people who are interested in this in the paper. Again, these inequalities are also across the life course. It's not a matter of just childhood mortality. So if you're thinking about particular ages, this is not really helpful because we are seeing that marginalization is playing out across the life course. Older people are affected, middle-aged people are affected, younger children are affected. And then finally, which this allows me to bring to the third paper that we did, which is that you would always say, or we always hear, oh, you're doing caste-based differences or social group differences. This is all class. And I think what we find out was that this is not all class. So what this graph shows is life expectancy at birth in 9 poor states in India from the annual health survey. So the annual health survey is large enough that you can create life expectancy by group, by wealth decile. The NFHS is not that large. And so here you see that, okay, across wealth deciles. So these are higher caste Hindus. So across wealth deciles, you see that Dalits and Adivasis have poor life expectancy for both men and women. So this allows us to say that, look, yes, class does play a role, but caste differences are independent of class differences. And if you may want to think about both as interacting as well as independent factors in contributing disadvantages. This is just the HS states. And so across states, we find that Dalits and Adivasis have lower life expectancy than higher caste Hindus. This is from the NFHS. From the NFHS, we can't do by state, but we are able to do by region. So this is the Hindi belt. And so the darker the color on this map, the greater the absolute difference between SCs, between marginalized groups and higher castes. So here you see the 6-year gap between SC women, 5-year gap, sorry. 5-year gap between SC women and high caste women. Here you see actually the gap is largest in southern states, right? So SE men have a life expectancy of 63.9 years in the southern states. This is much higher than North India. So if you are an SE man, you're better off if you are in South India, definitely. But it's also the case that it's not the case that if just because South India is richer, more progressive, that disparities don't exist in South India. We find disparities in South India as well. For Adivasis, we divide them into 3 regions: the Northeast, states of Central India, and the rest of India. And as expected in Central Indian states, Adivasis are doing the work. Adivasis have the lowest life expectancies when compared to higher caste. For the Northeast, actually, maybe not so surprisingly, in fact, we don't find large differences. In fact, sometimes SC life expectancy is higher than high caste life expectancy, although the confidence intervals overlap. And I think this goes on to show that the Northeast is marginalized when you compare to the rest of the country, but within Northeastern society, Adivasis are not particularly marginalized compared to other social groups. I will move on to life expectancy by class and region. So these are from NFHS 4. And so this is the poorest quartile for women. And so you have 64.7 among the poorest, 25% in UP, and 72.9 in Tamil Nadu, in states of South India, Tamil Nadu, Kerala, Karnataka, Andhra Pradesh, and yeah, what did I miss? I don't know. And I think it's important to move through this graph and look, if you can be the richest 25% in UP and you would still have poorer life expectancy than the poorest in South India, right? And 69.1 here and 72.9 here. And I think this particularly shows on the extent to which northern Indian states like UP are patriarchal for women across classes. Like it's not just it's like you can be very rich, but if you're a woman, you're really worse off in states like UP. I think finally I should say that there's greater variation within India, but within each class when you look at female patterns, and when you look at male patterns, actually basically men are fairly similar across contexts, right? So there's so I think this is also important that region, this is also useful to think about how region and patriarchy are shaping outcomes for different for men and women differently in different regions.
Ashish, I have a question for the last slide.
Yeah.
Is it also because that of the availability of primary healthcare centers or
Exactly.
other resources as well in the southern states and the North Indian states? Since UP is the most populous state in the North Indian belt, and the population dependent on a PHC is a lot. So could that also be the reason?
Yeah, I think it's not just population. I mean, Tamil states. I mean, Kerala is very dense across rural and urban contexts, right? It's one of the densest. It's one of the densest states in India. So it's not about population, but you're definitely right that this is about the provisioning of healthcare for the population. So you could very well imagine that you need, and so I think this is sort of one thing that we are not answering this, like what are the contributions here? To what extent is the social inequality? To what extent is this state policy? To what extent is this healthcare? And I think you're exactly right that these states are also really bad in terms of healthcare. So I think you then you have to answer this question. Okay, so why are they not for men particularly? So 61 and 62. You could say that healthcare is more important for women, and you would be right to some extent. But I think you have to think about social forces also, I think, in explaining these patterns. And so I think, and I would be happy to be proved wrong. And I think there's much more work needed on the exact reasons why we are seeing these patterns of life expectancy disparities. I promised some were from NFHS 5. So this is one graph that I was able to create from the recently released NFHS 5. And these are social disparities in life expectancy in India in 2017 and 2019. No surprises here. SCs, STs, Muslims, other backward classes, and high class. So difference still of 6 years here between scheduled caste and high caste, and 4 years between among women. Muslim life expectancy very similar to OBC life expectancy among men and lower among women. I think there's some among women. I think there's some evidence accumulating that disadvantages among Muslim women are further accumulating, and so they're very similar life expectancies as SC and ST men. I think for the reason why Muslim men are not doing as bad, I think one has to consider behaviors such as, for instance, they don't drink alcohol that much, and still, despite these behaviors, they have much lower life expectancies than high caste. So I think this is the last graph that I have, which, and so I'll summarize. What do we find? I think we find large, persistent, and consequential disparities from an Indian perspective as well as from a global perspective. So I think if you think about the population of Dalits, Adivasis, Muslims together, they're like the third largest country in the world. Any two groups are greater than the population of the United States. So we get within India, we care about life expectancies of these. We should care about life expectancies of these marginalized groups. But let's say you're not from India and you're from anywhere else. So even from a global perspective, if you want to improve health globally, you should care about the life expectancies of marginalized social groups in India, because they're just so large and so marginalized that if you improve life expectancies, you make a move on global life expectancy. Fine. There's another implication, an urgent need to focus on mortality disparities across the life course. And also, I think there's much more research needed on the exact reasons why. So the reasons, the causes of death that contribute to childhood disparities are different from adult disparities. So I think there's much more reason in what is causing marginalized social groups to have worse life expectancies across the life course. Finally, I think there's some evidence here that is helpful for us as we move forward. And I'm particularly excited about the questions other people will ask from these data and the kind of findings that they will have if they're able to use these data. I would say that it's not the easiest thing, because the NFHS, it's a large survey and then you're doing mortality analysis. So it does require some computing resources. But to the extent that we can help, we are very happy to help. We provided code from all of our papers that have been published. And I'm generally quite happy to think about what to do, and from these data that I think are chronically underutilized. Thank you.
Uh, Thank you, Ashish, for this wonderful talk. I think it was quite enlightening to know how the two systems measuring the same indicator could have so much inconsistencies, and it could raise a lot of questions, and how the inequalities among the such vital statistics could vary across class and caste and the regions. So it was quite enlightening, and I think we might have all of us has learned something new today. So, so I would open the floor for the questions. I don't see any questions in the chat box. So if you have any clarification or questions, feel free to unmute yourself and ask directly.
Hi Ashish, I wanted to ask if the standard errors are consistent across the research that you have been doing. Matlab, I do not think that you pointed it out. So if you could shed some light on it.
Sorry, GP, I don't know. What do you mean by standard errors being consistent?
As in how errors, like there's standard errors in some sense that you calculated, no? And there's also
Right,
this
right, right.
formula that you were using, that NaX. So what can
Yeah,
you
yeah,
shed some light on that as well? So
yeah,
and
yeah, yeah. Thanks.
and how the standard errors are shaping across the models.
Yeah. So the standard errors are following a standard bootstrap approach. So whenever, okay. So life expectancy. So when you do a regression would estimate the standard errors, pay a standard error for you, or when you're doing an estimate, a mean has a very standard formula for standard errors. Now, when you're doing life expectancy calculations, it's a non-linear function of a specific mortality rate, right? So whenever you're doing such where a formula for standard errors does not already exist, you have to bootstrap these standard errors. Bootstrap is like a fancy way of saying that basically you take this data, take NFHS4 that you already have, and you draw 100 samples from within the NFHS, right? Then you note each of the estimate of life expectancy that you get from the NFHS. And you just note them down and calculate the standard deviation of this. So every time you will draw a bootstrap, you will get a different estimate, right? And so if you repeat, if you your every every time you draw 100 bootstraps, you will get different estimates, right? So I think from our perspective, there are very minute differences. Once you do a large number of bootstraps, basically it gets very stable, and there are minute differences in life expectancy calculations, like in the standard errors, right? Uh, the other reason, so this is in any case for life expectancy, you have to do standard errors because it's a non-standard metric. The second reason why we need to do standard errors is, of course, because we have a clustered survey. Instead of drawing a simple random sample, what the NFHS does is it visits villages, and within villages, it randomly selects, say, 20 or 30 households, right? So instead of drawing people, we are drawing clusters uh, from the NFHS sample, from the NFHS data that we have. And so to answer your question, yes, every time you draw 100 bootstraps, you would get slightly different standard errors. But from our perspective, that doesn't matter because those standard errors themselves are very similar to each other. Yeah.
Okay, thanks. There's one more question in the chat by Mridula. So she says that what is meant by the usual members of the household? I think she's talking about the
Yeah.
survey that we do. Matlab,
Right.
survey, yes. So she says that I think it was mentioned on one of the slides with a reference to asking questions on mortality. So if you could clarify.
Yeah. So I think this is helpful. So every time when you do a survey, there is some question of oh, there is this member of the household, but currently they live in Delhi. Oh, this person is recently married into the household. but they have been here. So the marriage was 2 months ago, right? So do you count them as members of the household, or do you not count them as members of the household, right? So oftentimes surveys create a rule that okay, you count them this way in this regard, and you don't count them if this happens, right? Um, so the rule in the NFHS was if you were in the same household for the last 6 months in the last year, right? For 6 months, if you lived there, so even you could be a migrant, but if you lived in the place, I think the NFHS used the chula definition. So if you eat from the same chula, you're considered a member of the household. If you use from the same hearth, if you eat from the same hearth, then you're considered a member of the household. Then if you ate from the same hearth, for the last in for a period of 6 months in the last 1 year, then you will consider a member of the household, right? So that's the approach. And so we use usual members in both the numerator and the denominator, which is to say that for both dead people as well as for alive people, we use usual members of the household. Thanks for that question.
Thanks, Ashish. So if you have, uh, if anyone has more questions, so yeah, wait a minute, Mridula, 1 minute.
Hi, I think I've been able to unmute. Can you hear me?
Yes, yes, Mridula, we can hear you.
Okay, thank you so much for the presentation. It was like very enlightening and for answering that question. I had a general question that, you've showed us how differences based on caste, class, gender, and region kind of like they're persistent over the years and they continue to be like that. I was wondering what are the practical applications of these results that are already being taken? Are there any programs that are being designed keeping in mind the results that are coming out? Or any other things like, any novel approaches that you might have seen which take into account all of these parameters and
Yeah.
work on reducing mortality differently. Thank you.
Right. Thanks. I think, yeah, that's a really important question. So, I mean, I should say that I'm nobody and I have no connections to anybody. So I don't think anybody has paid attention to this because we did some estimates. I think it's important to say that think about how much effort we would put into think about life to improve life expectancy in India, right? So if you think about, we don't do it nearly as much as we should, but I think we as a society do care about life expectancy, and I think we should similarly care about life expectancy disparities. Now, in terms of programs and policies, I think what this research is showing is that uh, tackling that one thing is just growth. Uh, uh, so, for instance, in this period in between NFHS 4 and NFHS 2 and NFHS 4, there's been a lot of economic growth, right? And so we still find, despite this economic growth, we still find that disparities haven't reduced. What this implies is that there is a need to confront caste and other forms of social inequality on their own. I should say that there is some impact of the work on estimating mortality per se. And so, for instance, based on this encouraging evidence, as well as from other evidence, people are less skeptical of the question on decent deaths of household members. In fact, the WHO is considering recommending this question in the context of the COVID-19 pandemic. And I think there's more work needed, more experimental work is happening on how best to generate mortality estimates from survey data. To go back to your question on disparities, so to some extent, programs health programs in India consider social inequality based on caste, and but to a lot of extent they don't. And the other thing is that there's lots of discrimination even within healthcare settings. There are disparities in access to healthcare. Um, and so I think we would have to think about all those things that contribute to life expectancy when we are thinking about reducing life expectancy disparities. Finally, I want to mention that so for instance, in the US, there is a National Institute of Health dedicated to reducing disparities in life expectancy and mortality in health. So this is equivalent to creating an ICMR institute, which with an explicit focus on disparities in health in India, right? And so we don't have that. Thanks.
So Ashish, we have two more questions in the chat box.
Yeah, thanks for that question.
So Shrikant asked, I'm just wondering how did you adjust the quality of data reported for the age of deaths? I remember one paper on data quality, particularly mentioning that reporting of age of death is poor in NFHS 3. Did you adjust these before estimating or taking as reported?
Yeah, no, so I think this is a great question. We have chosen, so I can go back. So we have chosen not to adjust our estimates. And so to us, the NFHS estimates, the age-specific mortality rates that we generated are good enough to estimate disparities. We we did a lot of robustness checks. So for instance, there's something called, so we did the usual robustness checks. I think this audience, so I'll explain what happens. So there's a UN approach. What the UN approach does is it takes under 5 mortality, and then it takes adult mortality, and then it extrapolates estimates across the life course. So it extrapolates age-specific mortality rates for all ages, right? Or you can think about drawing a Gompertz curve through mortality rates between ages 30 and 70. This is a fancy way of saying that you model mortality, you model the log of mortality as linearly increasing with age. So when we do these approaches, basically they make no differences to life expectancy estimates. I would say that there is some value to not adjusting estimates. I understand that adjusting is fairly common. And I think the value in not adjusting estimates is to report the data as it is coming to you. And so if we think that, and so I think, and this is the approach that we have taken to be transparent. There are things, for instance, age misreporting, where this question is on average leads to lower mortality and higher life expectancy. Yeah. So this is established within the demography literature. So and so who is more likely to misreport their ages? It's poorer people, it's marginalized people, it's people with lesser education. So when you think about these are Dalits, Adivasis, the poorest 25% say. So because of age misreporting, their life expectancy is overestimated. And so if you account for age misreporting, you would actually find wider differences. So we believe that our estimates are actually quite conservative. And I think personally, I like reporting how the estimates will change with perfect data in words rather than do a lot of complicated maths to estimate something that we don't quite understand. Yeah.
Thanks, Ashish. We have two more questions from Akash, and one is a bit longer. So, Akash, if you want to go ahead and unmute yourself and ask directly, that would be helpful.
Hi, I'm sorry, Tausif, he cannot unmute himself. So you have to ask the question, please. Can you do that?
Yes. All right. So the first question is how to basically open the social questions that undergoes all poverty discourses, which dominates at least the elite decision-making quarters in the country.
Yeah, I think it's a great question. I don't know the answer. Uh, I, so I should say though that one thing that is, so when I was in college, we didn't have a lot of conversation on caste nationally, right? And I think we're having some conversation on caste nationally, partly because marginalized social groups are able to articulate what they think, and how what and they have greater ability to talk about their issues themselves, right? Uh, there is still, I would say, for instance, if one thinks of Adivasis, I think they're still absent from the national discourse, right? And so I think if you think about Adivasi issues, we used to talk about it in the context of Operation Green Hunt and then in environmental issues. And I think even then it wasn't Adivasi voices that we were hearing, right? We were hearing mostly voices of other elites. And I think that's like that's still missing, I think, in India. I think for good reason we are I think for basically given the increased marginalization of Muslims within Indian society today, this is the, we're having conversations about religion and marginalization based on religion within Indian society. Um, uh, One would like for us not to have reasons to have this conversation, right? So like this is easier to like if the government if the rise of Hindu nationalism wasn't so bad, then maybe we would not be so concerned about it. But we're concerned for good reason. Um, so I'm not sure what are the factors for that change, but I think but the increasing the ability of people to fight their battles is partly, I think, is a useful endeavor that we could contribute.
Uh, thanks, Ashish. So Akash has another question. I think it is more related to the causal factors related to the outputs we have seen. So he asked how to go from the outcomes to say processes and inputs. That is, if outcomes are differing across the social groups, how to map that to concrete scheme and concrete processes. Is this
Right.
available within the NFHS set?
Yeah. So some of these data, particularly I think on access to health, on the use of health, on the use of other public programs, is available from the NFHS. And I think it would be important to look at what um, how to what extent are disparities explained by disparities, say in access to healthcare, in geographic isolation of some groups, particularly I think of Adivasis, where healthcare facilities are not provided where they are, and I think also what and also I think where uh, the extent to which for instance, healthcare contributes to disparities. What is not available in the NFHS are information on, say, how much discrimination people face within healthcare settings. What is not available is how much discrimination and violence and exploitation people face within their life, right? So you can very well imagine somebody try. You can very well imagine some people trying to improve their lives and trying to get access to better things, and then facing violence or oppression. Then, right? Uh, and I think that would be useful data to collect. That's not yet collected in the NFHS.
Makes sense. Thanks, Ashish.
Thanks,
So
Akash.
So we do not have any more questions in the chat box. So it's a good time to close. So thank you, Ashish. Thanks a lot for taking out the time for having a session with us. And we would like to see you in future as well.
Yeah, thanks.
So
Yeah,
yeah,
same here. Thank you.
yes.
Thanks
So
for
before
having me.
everyone
Thanks
leaves,
for these questions.
yes. So before everyone leaves, I would like to make an announcement that we have our next session with Avinash Kumar on 3rd of July at 7 p.m. So the details would be circulated through the via email. So thank you everyone. Thanks a lot for joining in.